Hi, I'm Dr. Townsend, and I'm going to be going over with you chronic kidney disease, just a brief overview. First, we'll start off with the definition of chronic kidney disease. This encompasses kidney damage for greater than or equal to 3 months with or without decreased glomerular filtration rate manifest by either pathological abnormalities or markers of kidney damage, including abnormalities in the composition of the blood or urine or abnormalities in imaging tests, and glomerular filtration rate less than 60 for greater than or equal to 3 months. And that should be a little 2 right there. The two primary causes of chronic kidney disease are diabetes and hypertension. This is, in the U.S., it's about 70% of the population that has chronic kidney disease. That's the cause. So diabetes and hypertension are the primary culprits. What can you do as a nurse practitioner to help your patient? You want to increase your testing of urinary albumin of at-risk patients, monitor their eGFR and albumin creatinine ratio, increase the use of ACE and ARBs, but you don't want to do that together. Avoid NSAIDs prescribing in at-risk patients, specifically those with low eGFRs. Now, you want to just decrease your prescribing of NSAIDs as much as possible in general, but specifically with these patients. Consult nephrology early, starting at stage 3, particularly by the time they get to stage 3B. You want to go ahead and start talking to the nephrologist. Educate the patient on chronic kidney disease and treatment. They need to be aware that they have an issue and what they can do themselves with watching their sodium, managing their blood pressure, their diabetes, staying as optimal health as possible. So they want to do all they can to be healthy, not drinking a lot of sodas and not using NSAIDs. Closely manage diabetes and hypertension. By that I mean optimally control them. Y'all had some instruction on that already, so that's what we're talking about here. Don't just look at your patient's blood creatinine level or your albumin creatinine ratio, but also be sure to check their UA. I'm putting my plug in here for when you're doing screening exams or their annual yearly wellness exams to check a UA on somebody. Insurance is paying for this. You may have someone who is completely unaware that they could potentially have a kidney issue or chronic kidney disease, and the first thing you pick up could be the proteinuria. Because, you know, when you just do a UA, you may get a low pH, high specific gravity, protein in the urine, along with RBCs and WBCs. These could alert you to potential problems early. So, you know, think about that. Let's be as proactive as we can be to help our patients. This is a nice little heat map. This is very helpful for you to tell you about CKD, and it's classified based on the cause and glomerular filtration rate and albuminuria, and it kind of breaks it down as to, you know, the green is people that are healthy, and as the color gets darker, the people get sicker, and in essence. So when you're thinking the person has less than 15 for their eGFR, you know, they're end-stage renal disease. You are thinking you are got them on dialysis, or you're doing palliative care because they're opting, you know, hospice palliative care issues, and they don't want to be on dialysis. They understand that their kidneys have failed. So that's where we are with that. Make sure you look over that. This also tells you kind of when to refer a patient, how often they should be seen in follow-up, which I think is very helpful. So you see, you're going to be seeing those people with advancing kidney disease 3 and 4 times a year. And probably more than that, they're going to have complications with other things, infections and other stuff, but at least it lets you know and when to refer them out to nephrology so you can get an idea. Clinical evaluation of chronic kidney disease. Many labs are done in the workup of chronic kidney disease, but starting by stage 3, especially 3B, most lab work is required. More lab work is usually required. Additional lab work beginning at stage 3 are your serum albumin, your phosphorus, calcium, intact parathyroid. You want to get some of these labs on this patient because they're going to start, as we've talked about, having problems. And when you're in your reading, you will see when these things start kicking in and they start having issues. Chronic kidney disease is one of those conditions where people don't have any symptoms and they don't know they've got a problem until it's often too late. So it comes on over months to years, so it's a slow progression. And so, you know, look over that and see when those things start happening. Tips when you're reading some of this on CKD, albuminuria, normal ACR is less than 30, so your albumin creatinine ratio is less than that. If it's severe, if it's greater than 300, and so, you know, when you get somebody with it over that, you know, and it's over 30, you're going to be putting them on an ACE, an ARB, you know, something to try to help bring that down. Proteinuria, greater than 30 in the urine dipstick. If it's stage 3, the patient will begin to have some complications like we talked about with chronic kidney disease. They're going to start having some anemia, bone and mineral issues. You know, they may have a spontaneous fracture, or if they fall, they will fracture often. Cardiovascular disease issues, you may have them getting into volume overload, low serum albumin. So be aware of that. When they have chronic kidney disease, you're going to treat their lipids with a statin or a statin plus ezetimibe. For patients that have chronic kidney disease that are not on dialysis. Review the patient's safety related to chronic kidney disease and diagnostic studies with contrast and all these preps and mediums, because those can be difficult for patients. Say if they're going for a colonoscopy or if they're having some dye study that you're ordering, be aware of that, be cognizant, because you can shut the person's kidneys down, do a lot. You can potentially do more harm than good. So always weigh that out when you're dealing with someone who's got progressive chronic kidney disease. It's pretty advanced. Avoid NSAIDs in chronic kidney disease patients and bisphosphonates. So you've got a balancing act there. Renal diet. It's important for patients with chronic kidney disease to consult a dietitian. You want to choose to prepare foods with less sodium and use less salt at the table. You don't want them shaking it at the table, and you don't want to cook with it. No more than necessary. You know, try to keep that minimized. 2,000 milligrams or less. Select the right kinds of food and smaller amounts of protein. You want them to eat fish if, you know, when they're eating. That'd be good. Stay away from red meat as much as possible. Choose foods that are heart healthy is what you're looking for. Lean cuts of meat, skinless chicken, fish, fruits, vegetables, beans, that kind of stuff. You want them to get comfortable reading nutrition labels and looking at the sodium. Help them pick the right food and drinks. Avoid sodas. Lipids, we talked about that already. In general, if they're not on dialysis, they're going to be on a statin plus or minus ezetimibe. They may be on ezetimibe, but they will be usually on statin, or should be. Okay, complications of chronic kidney disease. A lot of them are listed here. You've got the sodium balance issues with sodium retention and volume overload. Initially, you're going to have diuretics. In the early stages of chronic kidney disease, they'll be on like a thiazide diuretic, and then once they get later on in the disease process, they'll move to a loop diuretic. Usually by once the eGFR is like 30 or below, they're going to move to like a loop diuretic. All right, potassium excretion, they're going to be prone to hyperkalemia, so you're going to have to check their potassium pretty regularly, particularly if you do any med adjustments. If you put them on an ACE or an ARB, you know this person is chronic kidney disease person. You got to check them within like 7 to 14 days. And if you do any adjustments, be aware of that. Also, no dietary restrictions with potassium. So, if you got a huge banana eater, you might better tell them, kind of calm that down and avoid the NSAIDs, as I said. Acid excretion, metabolic acidosis, they're going to be on sodium bicarbonate, calcium phosphate balance, phosphate binders, Then you have anemia, and you might have to have the iron or erythropoietins. And then you discuss that some here, where exactly what's done to treat that. You don't have to get all into the weeds about this too much, but just know that you will have to be treating anemia, and that they will have these complications. You need to know what the complications are likely to be. With phosphorus issues, that happens when they get to stage 4 and 5. End-stage renal disease signs and symptoms. I put this little slide in here, this little cartoon slide, but it's not funny. These people are very sick. Some of the sickest people you'll ever take care of can be your chronic kidney disease, end-stage renal disease patients. They have a whole host of everything wrong with them. And you'll see neurological issues with them being confused, weak, all that. With psychological overlays, yes, you will get all of that, because they are very depressed often. They're very frustrated, irritable. Mood swings can swing wildly because they're having buildup with some of these toxins in their body, but also the loss of function in their life is being greatly impacted if they're back and forth at dialysis 4 times, 3 and 4 times a week. I mean, that can be pretty draining on them and on their family members or support system. When you think about hematologically, they will have anemia, they'll have bleeding tendencies. Potassium, as we talked about earlier, is likely to be easy to elevate, and they'll get into trouble that way. So you need to check that pretty often. Skin is going to be dry, flaky, itchy. So they'll, bruise easily. They'll have kind of a grayish yellow cast to their skin often, and they just look sick. They have muscle cramps and bone pain. Think about the process that's going on, so that makes sense when you think about it. GI, they'll have the nausea, the anorexia, they'll have a metallic odor, metallic taste, and the bad breath. They get sores in the mouth. As we talked about earlier, volume overload is common with these people. So, when they start getting into trouble, make sure you get them in and get them seen. I also put the slide on here for you to be able to recognize a person when they present. because not everyone that you will see will already be set up with nephrology. You will have people walk in off the street that will be basically almost at end-stage renal disease and will be seeing you for the first time, unfortunately. So be aware of what this type of person looks like so you can get them, try to do the best for them you can. Remember, caring is a core value of nursing. It's a pillar of our profession. So I just leave you with this parting thought from Helen Keller to try to do all you can for these people who desperately need you, who have chronic kidney disease.